chronic respiratory disease patients. How can I move forward? Okay, hold on. Right. So the commonest symptoms that we have to palliate is breathlessness and cough in advanced disease. So today I will take you mostly through breathlessness, and that's because I've been asked to talk to you on breathlessness. But remember that cough is also a problem when it comes to palliating respiratory symptoms. So first about the prevalence and the impact. Next, it will be about definition, mechanisms, how to assess a breathless patient, what are the treatment modalities we have, and few of the salient key points that I want you to remember at the end of this. So if you've been listening in the morning, you will know why we are worried about symptoms such as breathlessness, pain, constipation, fatigue, loss of appetite. Can anybody give me an answer to this? Why are we worried about the symptoms? Why do we want to talk about a symptom such as pain or a symptom such as breathlessness and not talk about a particular disease? Well, that's because irrespective of what the original illness is, for example, whether it is chronic respiratory disorder or whether it is chronic heart failure or whatever the disease that is creating this limitation in life and creating a life-threatening illness, there is a group of symptoms that really dictate what the quality of life of that patient is going to be towards end of life. Okay? So the patient who has heart failure, patient who has chronic kidney disease, patient who has chronic respiratory disorders, when they are dying of their illness, these symptoms tend to come together. There will be some element of pain, there will be element of breathlessness, constipation, etc. So it is important that we identify these symptoms and address them, because that is the way we can holistically look into this patient and improve their quality of life. Right. So, though we think that breathlessness is common in respiratory disease, it is in fact quite common even in patients with cancer. It is common in patients with heart failure. It is common in patients with chronic kidney disease. So, it is a very distressing symptom, and the prevalence and the intensity of this increases as the patient approaches death. So, like I said earlier, of course, in patients with respiratory failure, breathlessness tends to fluctuate, go up and down throughout their entire illness. But with patients with other non-cardiorespiratory diseases also, along with cancers, tend to have progressive breathlessness, which gets worsen and worsen as time goes by and patient nears death. So it is everybody's business who manage patient, for people who manage palliative care patients, it is everybody's business to know how to deal with breathlessness. Right. So what is in fact breathlessness? What does it mean to you when the patient says he has breathing discomfort, right? And is breathlessness the same as hypoxia? And do you think that breathlessness directly correlates to hypoxia? So that's the question I'm asking you first, and I want you to really think this through, and I'm giving this explanation to you about what is the mechanism of breathlessness. Now, we have the respiratory center, and we all know that. Then there is, from the respiratory center, we get inputs into the respiratory respiratory system, which is, it's from the lungs and the inspiratory and the expiratory muscles. So from the respiratory center, we have feedback mechanisms to and fro to the respiratory system. Agreed? Okay. So when a person starts let's assume a person who is sitting down in one place suddenly starts running, right? Then there is an increase in the demand for oxygen. So what does the feedback mechanism tell the respiratory system? It says, look, now you need to get your oxygen levels up. So start working faster and better. So that is why we have increase in the respiratory rate and increase in the tidal volume, or the volume of air that we breathe in and out, that is increased when the demand is more. So that is why on top of this little graph I am showing you, not graph actually, the picture I am showing you, there is a perceived need. The body recognizes that, and there is actually an action that is taken, which is called the physicality of breathing improves and a response is achieved. Okay, so that is in a normal, healthy individual. But what if there is a disorder in the respiratory system? Then the appropriate response can't get achieved. So you cannot meet the demand. So the demand is there, the supply is not there. So there is a mismatch. And that mismatch is the starting point of breathlessness. That mismatch is called hypoxia, right? And when the patient is hypoxic, the patient experiences breathlessness. Agree? Right. But is it the same as what we call as why is an hypoxia and breathlessness the same? That is because even though hypoxia is something we detect, breathlessness has other elements that involved in how a person perceives his breathing discomfort. Right? So there are actual inputs that come from the limbic system and the cortical system of the brain as to how individual people perceive their hypoxia, right? So let's imagine a person who is very anxious, who is very emotional, who is very vulnerable to anxiety. So these people, through their limbic systems, will have an impact on how we perceive breathlessness. Then people who are very fearful, they have beliefs, they have past experiences which are negatively going to affect this patient. Through the cortical system, they will also have another input into the respiratory center, and their perception will get further aggravated. So remember, hypoxia is the physical problem that we are facing with, but breathlessness is something beyond that. Breathlessness gets clouded by how a person receives his inputs from the cortical system and the limbic system. So this is very much similar to pain. Agreed? How you feel pain is not the same as how I feel pain. Different people have different pain thresholds. That is because there is inputs, it's not only the physical problem, there are different inputs from the brain that influences how we perceive this problem of pain and breathlessness. So that is why, by definition, breathlessness is called a subjective experience of breathing discomfort. Okay? It is what the patient tells you. It's what the patient experiences. And it has qualitative differences between the intensity and the sensation. So this is a very complex definition simply because it is not just mere hypoxia. Okay? So it's what the patient experiences, same as pain, what the patient experiences and what the patient describes to you. And this experience starts with a physiological problem, but is influenced by psychological, social, and environmental factors. And so have you understood that? Okay? So it's very important that you remember that hypoxia is something different, breathlessness is something different. And these patients will have different physiological and behavioral responses. So simply, if I tell you that a person who's breathless will start breathing in a different abnormal manner, and they will have a behavioral response. That means it can trigger anxiety and panic in these patients. So, to start off with, we have psychological problems that influence breathlessness, and then we have a vicious cycle which starts off where the response worsens the anxiety in the patient. Okay? Do you have any questions up till now? No? If anybody has a question, you can ask me. We have 1 whole hour to discuss this. Right? Okay. So I want you to remember this before we go forward. It is a subjective experience of a breathing discomfort. I am sure even you have felt breathless in spite of not having a respiratory problem. For example, you are just waiting outside, let's assume a Viva room, and you're about to go in. I'm sure we all have felt discomfort in breathing. And this can only be told to you by the patient. And it involves a complex set of interactions between actual physical problem, the psychological and the emotional factors. Okay? Right. So now you have a subjective symptom, but you still need to make it an objective assessment, right? So when you are trying to quantify a person's breathlessness, remember, severity is important. That means how severe are you breathless? Okay. How does it affect you? So severity is important, but not only severity, what is the affective component? Affective means how does it reflect upon your mood? What does it do to your feelings? Do you feel unpleasant? Do you feel panicky when you feel the breathlessness? So severity of the breathlessness as well as the affective component is important in these patients when you're measuring breathlessness. And I will tell you a few tools where you can make this very subjective symptom into an objective assessment. Okay? Right. So then when you're looking at again, this is again to tell you when you're measuring the severity, you can ask them, what is your breathless for? How do you feel breathless now? What is your average? What has it been during the last maybe 24 hours or 2 weeks? How breathless have you been? What has been your worst? So you can try to quantify the severity by asking questions. But remember, it's not only the severity that we are taking into consideration, we are also taking the affective component. We have to, in our history taking of breathlessness, how does it make you feel? Okay? Does it make you feel panicky? Does it make you feel anxious? Are you worried about suddenly stopping breathing and dying because of breathlessness? So, the intensity of breathlessness is what you and I always ask. I'm sure we have different NYHA scoring systems. We have MMRC scoring systems. Similarly, even in pain, we have the pain scale. We ask them how painful is it to you. So similarly, we can try to quantify or see how severe it is. But there is good evidence that intensity is not that important. And what is more or equally important is how unpleasant does this make you feel. Because remember, if you don't realize the affective component, we can't address it. And if we don't address it, it becomes part and parcel of the vicious cycle that drives the breathlessness. Okay? And remember, intensity and unpleasantness may respond differently to the measures we take. We can give something to reduce the intensity, but it will not take away the unpleasantness. Right? So when you're history taking, remember you have to take both components of breathlessness. So this is another tool which we can use, which can give this some sort of an objective measure to this subjective symptom on the severity of the illness. Okay, how severe is your breathlessness? So this is something that we as respiratory physicians tend to take into account all the time when we are describing dyspnea or breathlessness in a patient. So this tells you, okay, I can't, I'm too breathless. So you should start off MMRC 0 means he only gets breathlessness with strenuous exercise. That's probably us. Okay. Then MMRC 1, this person gets breathlessness when hurrying on the level ground or walking up a slight hill. Then level 3 or grade 3 would be when walking on level ground but walks slower than other people of the same age because they are breathless and they have to stop for breathing even when walking at my own pace. Then grade 3 becomes stops walking after 100 yards or in a few minutes. And grade 4 means I'm breathless even to leave the house, right? And even when attending to activities of daily living. So when you are serially following your patient up, you will have to know, okay, this particular patient was first in MMRC4, and after doing a particular intervention, let's say I will tell you about the interventions later. Now he has moved to an MMRC3. So it's important, though this symptom is something that they only describe to you, that is what they feel and they are only able to express to us. But once they express it, we need to know how bad it is to them. So we need a tool to make this subjective symptom into an objective measure. Okay? Right. So it's important that you use some tool as this so that when you do the intervention, you can see how good they become or whether they make whatever we do makes a difference to them at all. Right. Sorry. Okay. So let's talk about how you should now say. Let's assume a simple example such as a patient with lung cancer. Okay. How should you assess your breathless patient? So I showed you how to measure the breathlessness, but what should you look for in your breathless patient, right? First thing you need to know when a person comes to you and they are breathless, you look for all potentially reversible causes of breathlessness. So remember, if a person has a lung cancer, he can simultaneously have a airway problem. He may be a case of COPD, right? The patient may have gone on to develop a pleural effusion. So, just because we have to palliate the symptom breathlessness, it should not be that we do not look for reversible causes. We have to all the time, even in pain, you have to look for reversible causes, right? And one person may start off with one illness, but may have other co-founding illnesses that make this particular symptom worse. So look for them. Ask yourself, common things occur commonly. So can he be an asthmatic? Can he be a case of COPD? Does he have developed a pulmonary embolism? So as of always, before you start palliating the symptom breathlessness, look for potentially reversible causes. And some of these reversible causes are yet again narrated here. It can be that patient is having an underlying infection. There may be metabolic reasons. Okay. There can be pulmonary edema or heart failure that is common in patients with COPD. Most often they go into pulmonale even without our knowledge. So they may be having cardiac issues. So look and manage any reversible problem. But remember, when you are going to investigate them, now you're here to palliate the symptom breathlessness. You're looking for reversible causes. But when you undertake to investigate a palliative patient, always set yourself goals of care. What do I hope to achieve by performing this investigation? Right? If I hope to change my management or look for something that's going to make a difference for the patient, then do so please go and investigate that patient. So, knowing that it's not going to make a difference, knowing that you're just only doing it for the sake of doing it, don't embark on investigations, right? So that is why when you're going to palliate breathlessness, let's say in an end-stage COPD patient, set yourself goals of care, right? What am I going to achieve by palliating this symptom? Am I going to improve quality of life? Am I going to improve this patient's physical exercise tolerance? So whatever, sit together, think about what you're going to achieve, and when you're investigating even for a reversible pathology, of course, don't embark on high-end investigations unless it's going to change your management. Okay? And therefore, each decision on how much to do things for patients will depend upon their individual patient and their needs. So we looked for a reversible problem, right? Then what should you do? They must optimize the treatment of the underlying condition. So what does this mean? It means that curative treatment and palliative treatment are going in hand in hand. Okay, that means you're not going to give up on the inhaler that you have given to the patient. You're not going to give up on heart failure management. You're going to simultaneously start your palliation of the symptom breathlessness along with while the optimum treatment of the underlying condition is going on. This is more so for patients with organ failure. In cancer, it may be a different option. You may decide to withhold treatment, curative management, but in chronic illnesses, that is the mainstay for chronic breathlessness, we manage the optimally the original condition that led to the problem while we simultaneously look for treatment of breathlessness. Do you get that? Yes? Okay, right. So, when we have looked for the reversible, so just remember one patient, so just assume we are talking about a COPD patient, okay? You look for reversible problems such as maybe cor pulmonale or anemia. Then you optimize COPD management, and now you are left still with chronic refractory breathlessness. That means the patient is going to be breathless irrespective of whatever you have done, right? Now we have to embark upon dealing with this chronic refractory breathlessness outside of the disease COPD, and that is going to be the mainstay of my talk today, right? So remember, this is more so for patients with chronic kidney disease, can be for chronic patients with chronic heart failure, they can be for chronic respiratory diseases. So these in organ failures tend to have breathlessness, which is refractory to the management of its original problem, which can be the organ failure. So how do we treat breathlessness as an independent clinical symptom outside of the original illness? So that is going to be what you are going to learn new. Okay? Right. So remember, I said breathlessness is a subjective symptom. Okay? And it is what the patient perceives. And it has many influences. Similarly, when you're looking at a chronically breathless patient, you have to remember there are these three vicious cycles that make that person's breathlessness worse, right? For example, just imagine a COPD patient. These COPD patients, if you have observed their breathing, you will realize that they are basically gulping down air. They are taking a very fast breathing. Their inspiratory effort is very high, but they don't allow time for the expiration. Before the expiration is completed, they again do an inspiration. So in a normal healthy individual, you have an inspiratory arm when you breathe in. Then you have an expiratory arm, which is when you breathe out. And generally, the expiratory arm is 1/3 the time of the inspiratory arm. Okay? But in COPD, they have very short expiration. They are breathing in, very short expiration, breathing in again. So they gulp down air one on top of the other before actually letting time for the lungs to empty. So when the lungs don't empty, there is dynamic hyperinflation of the lung. The lung becomes more and air gets more and more trapped inside the lung. That is why you have a barrel-shaped chest in a COPD patient, because there is air trapped. Air is not given time to expire, right? So this is what we call as an inefficient breathing technique. So when a person has an inefficient breathing technique, it creates a ventilation perfusion mismatch, and it further aggravates the hypoxia. So hypoxia is because the lung is diseased. But on top of that, there is a inefficient breathing also going that is trying to compensate for this hypoxia, but actually making it worse, right? So next time you see a COPD patient, look at him. Look to see how is he breathing. Is there inefficient breathing in this patient? Right? Okay. This might be the case even for interstitial lung disease patients or bronchiectasis patients. They don't because the respiratory system is trying to compensate, but the compensation is actually working against the efficient breathing of an individual. Okay. Then we come to what is called as the thinking cycle. So in the thinking cycle, it is what the brain is telling the patient. Okay, the limbic system is telling the patient you're going to die, your breathing is going to stop very soon, right? And the patient develops panic and anxiety and distress, and this further precipitates inefficient breathing technique, right? So thoughts about dying, about misconceptions, about past experiences, like I said, there is actually a scientifically proven input from the limbic system and the cortex to the respiratory centers that drives the fear factor in these patients. So when you are evaluating your patient next time, you need to find out how much of this thinking cycle is playing a part in the breathlessness. Okay, how much panic is there in this man? So now we come to the last cycle, which is the functioning cycle. Now, what happens here? Now the person is inefficiently breathing. The patient is also having panic. So what does the patient do? He becomes more breathless and he is fearful of doing any physical activity. So he stops going out of his house. Then he stops doing his activities of daily living. He will be reluctant to bathe. He will be reluctant to cook his own food or go bathe him, to go to the toilet. All those things become a problem. Then the patient progressively becomes bedbound, right? So he wants to sit in one place or sit on the bed or sleep it off. And what happens to your muscles? So you know that if a person is in the same place for a long time, for example, patients in the ICU, their muscles undergo deconditioning. So the deconditioned muscle is very, very inefficient at utilization of oxygen. So whatever the oxygen that the body is able to provide, the muscle is not able to efficiently use. So the muscle is now working against the patient. So he has an inefficient muscle, he's breathless, he becomes homebound, leads to self-isolation, right, and social isolation, and that further reduces the quality of life and worsens the anxiety. So what I am trying to tell you here is there are three prongs that are working against this man who is breathless. And you need to recognize them independently of the disease, the original disease that you're talking about, right? Because we can do things that can actually improve each of these cycles, right? And that is the whole aim of identifying breathlessness and managing it in an individual patient. So, just again to tell you, in the breathing cycle, if it is the main problem in a patient, they have dysfunctional breathing patterns, and breathing retraining and other interventions such as controlled breathing techniques can actually be most useful for them. So I will take you through what is breathing retraining and breath control measures. Okay? Right. So if thinking cycle is the problem, right? If it is the most predominant part of breathlessness, and remember, I will show you a few examples where thinking has been the biggest problem, right? Then these patients may have unhelpful beliefs, unpleasant experiences, and almost all our COPD or heart failure patients have that. Okay, they may have one trigger event where that they were taken to a hospital and given maybe BiPAP or CPAP. That might be the trigger event that color their thoughts and feelings about breathlessness. And tomorrow I will show you an actual example of a patient whom we palliated who was end-stage COPD, and I will show you how a detailed history taking will really show you the insight into a patient rather than a disease, because what we are doing now is we are treating a disease. We are not treating patients when we are dealing with COPD, okay, or for that matter heart failure. So what we are in a conventional thinking process, we are looking at disease. Have we optimized COPD? But we have not looked at a patient and his individual requirements, right? So for the thinking cycle, giving them correct information, just simply reassurance can be something that helps them to overcome the thinking cycle, right? So the functional cycle is what I told you earlier. It functioning, if the patient becomes less and less functional, it creates a deconditioned muscle. And this deconditioned muscle has a different structure to those that muscles that regularly exercise. Okay, so the actual structure of that muscle changes. And what happens here in its metabolism, the muscle produces lactic acidosis because it's not efficiently utilizing its oxygen. It goes into anaerobic metabolism and produces lactic acidosis. And this lactic acidosis further worsens the fatigability of the muscle. So even if the patient wants to move, he can't because there is muscle fatigue. Okay, so it becomes a vicious cycle. Patient is breathless, patient rests, muscle undergo deconditioning, then an inefficient muscle is unable to use oxygen properly, undergoes anaerobic metabolism, and quickly undergoes fatigue, and patient becomes more breathless at a lower level of exertion. So this is called the spiral of disability. So we need to break this spiral of disability, and I will show you how we do that. Right. So this is again something in your history you need to know, that there are three cycles that drive chronic refractory breathlessness. You need to know and take an adequate history when you're doing that. And when you do that, you will know that there is one cycle which is more prominent than the others. And this cycle is the one that you may have to address first. But in most patients, all of these three cycles are equally contributory to the patient's worsening breathlessness. Okay? Right. So this is a simple example of an actual patient. This is Mr. F, who was diagnosed with end-stage COPD. He has recurrent admissions to hospital, but at home he is on home oxygen. But he comes into the ward every month closer to the POA day. He becomes very anxious if he is given the acute bed. Maybe he had a trigger event on the acute bed some time ago, and becomes even more breathless when a particular medical officer is doing the night on call. So you can see that this man's dominant cycle that drives him into hospital, his breathlessness is driven mostly by the anxiety cycle or the thinking cycle. And if I don't know this or identify this, what I will do is I will keep changing his inhaler. I will keep doing all sorts of pharmacological maneuvers, but it is not going to stop this man from coming into hospital. Right? So remember, when you look at your patient, look at him from different angles. Think, what is going wrong here? Okay? And I may have to do certain other maneuvers to overcome this vicious cycle in this man. So I'm not denying that there is COPD. I'm not denying that is an important factor, but I'm also asking you to recognize that there is something more to this man's breathlessness. Okay, so this is another example that I had when I was working in Kalutara. Now, this is an unmarried lady, 61 years, living alone with very poor family support. And she has breathlessness and has gone to several practitioners, and she came to me with 3 inhalers being prescribed to her. And during one of her previous consultations, somebody has taken a chest x-ray, and there was an incidentally found elevated right dome of the diaphragm, and this lady becomes very panicky about this situation because they have explained to her, your diaphragm is elevated, etc., etc., and she becomes even more anxious about this new finding. So, to reassure her, we did an ultrasound scan of the diaphragm and the movements were normal. Then that was not enough. We had to do a CT chest. And even that was not enough. And we proceeded with a spirometry study. And every time we investigated, it was normal. But she kept worrying about her breathlessness and her X-ray abnormality. So she was reassured. And so remember, when somebody gets triggered, right, that trigger may be unsubstantiated or may be very valid. But whatever it is, it can drive the breathlessness. So here again, a person who apparently was physiologically normal has a symptom that is being driven because of the thinking cycle. Okay, right. So how do we treat these patients? We have none, as of anything else, we have non-pharmacological measures and pharmacological measures. So I will tell you a few of the non-pharmacological measures that you can also practice. Say, let's assume your COPD patient has an inefficient breathing technique. Okay? Then what do? You teach them certain maneuvers. You teach them controlled breathing techniques. You can give them airway clearance techniques. Some of these things the physiotherapists know about it. I will teach you tomorrow a little bit more about what these mean. But you can do what is called as reinforce the breathing techniques to these patients, right? And I will tell you a few of it today as well. If you think that what are the non-pharmacological measures of managing the thinking cycle, so don't at once jumpstart these patients on anti-anxiety treatment. Okay, you are again adding on to the pharmacotherapy. Remember, non-pharmacological measures are equally effective as pharmacological measures in managing a patient. You just need the time and the effort to do so, right? So if it is thinking cycle that is driving it, you can teach them cognitive behavioral therapy, you can teach them relaxation techniques, meditation, mindfulness, acupuncture, all of those things can also improve the thinking cycle. Then we go on to, if the functioning is the problem, then we can do small things such as giving a walking aid, promoting activity, teaching about pacing, right? And then finally, or most importantly, not finally, pulmonary rehabilitation. So I will take you through few of these non-pharmacological interventions that you can do. We know this forward positioning and pursed-lip breathing. I will show that to you. Have you seen your COPD patient sitting forward with his arms stretched out? This is a natural posture that some COPD patients take, which is called the tripod positioning. Now, the tripod positioning has a physiological basis behind it. When a person leans forward and fixes the shoulder girdle, it improves the efficacy of the accessory muscles. And when the efficiency of the accessory muscles improve, it actually improves the gas transfer. So in your COPD patient who is breathless, teach him how to take on the tripod position and do the pursed-lip breathing. What does the pursed-lip breathing do? It stops the premature airway collapse and gives more time for the act of expiration and gives more opportunity for the patient to empty his lungs. So tripod positioning and pursed-lip breathing are sometimes what COPD patients naturally do. But if they haven't done it or they don't know how to do it, then teach them how to do it. So when they're sitting in one place, they will have a more efficient breathing and improvement in the gas transfers. Okay, give them a walking aid. What does a walking aid do? It makes the patient anyway lean forward. Again, something that we want to do to improve breathing. And it also gives the patient confidence to walk. And we know we want them to walk because walking improves the functioning cycle. Right? We need to give them a facial cooling handheld fan. Right? You know that when you feel really breathless, sometimes, even you and me, we would go to a window and open the window out. Right? We want to feel the air movement on our face. And that is because naturally, when air moves in front of your anterior nares, that means in front of your nose, it interrupts the signals from the upper airway to the brain stem, telling it about your breathlessness. Okay, so the signal gets interrupted, so the awareness of breathlessness reduces. Right? So air movement is extremely important for the breathless patient. So when a breathless patient comes to your ward, don't put him in the cornermost bed. Put him next to the window. Have the window open. Maybe the fan will be moving over his head. Air movement is very reassuring for breathless patients, right? Similarly, you can give a small handheld fan to their hand. I mean, we do this quite effectively. When you give a fan and you ask them, whenever you go through a panic attack or you're scared that you can't breathe anymore, hold the fan to your face. Of course, they have to be careful they don't injure themselves, but it is at about, I think, about 6 to 8 centimeter distance. They can hold the fan to their face and have air movement around their anterior nares. And this interrupts the signal that goes to the brainstem and it helps them to overcome the panic, right? Even when they are exercising or when they are moving, walking up and down, they can hold the fan to interrupt the feeling of breathlessness. And Okay, they are battery operated, or sometimes they can get plugged in and charged. And these fans are very helpful in the palliative setting. So again, this is a study that I wanted to tell you, that there is a significant difference in the visual acuity score between two treatments to reduce breathlessness. One was when the fan is held to the face, and the other one was when the fan was held to the leg. So then I spoke to you about pulmonary rehabilitation. Pulmonary rehabilitation is something that we do to improve the functioning cycle. Okay? So we know that they have a spiral of disability. We know that they are immobilized because of many factors. We want to make a more efficient muscle. So to make a more efficient muscle, we engage them in a comprehensive program going over a period of 6 to 8 weeks. And during these 8 weeks, we introduce them to graded exercises that gradually improve their upper limb and lower limb strength and endurance. Okay, so that patient then can start walking, can start engaging in activities of daily living. So the idea is not to improve the lung function, right, but to improve the exercise capacity of a patient. And you know that a mobile patient is the only patient who has a good quality of life. No bedbound patient has a good quality of life. Okay, right. So here again, a study, a Cochrane analysis of 12 studies have shown a clinically meaningful improvement in breathlessness. So even once the muscle becomes efficient, the symptom also reduces. Okay, so there is a clinically meaningful improvement in breathlessness in a patient with chronic undergoing pulmonary rehabilitation, right? And not only the physical exercise, we also engage these patients in a nutritional assessment and whether they need nutritional support. We talk to them about psychological issues, about anxiety, depression, and a lot of this goes unnoticed. Okay, and we also give them health education. So that is why it becomes a comprehensive program and not just an exercise program for these patients. So through pulmonary rehabilitation, we may be breaking the functional cycle, we may be breaking through the thinking cycle as well as the breathing cycle. So all three cycles will be dealt through the rehabilitation program. So anxiety reducing interventions, what are the non-pharmacological measures? I mentioned this to you before: meditation, cognitive behavioral therapy, mindfulness, all of that will help. Right. So we talked about the non-pharmacological measures. Now let's talk about, can we actually use a drug to improve breathlessness? Just to improve the symptom, not the underlying disease. Okay. Yes, we can. We use opioids. And opioids are the mainstay of any form of pharmacological intervention for breathlessness. And how does it work? Now we know breathlessness, irrespective of the cause, whether it be heart failure or kidney failure or respiratory failure, we know it activates an area in the limbic system of the brain. Now, the limbic system is rich in opioid receptors, and it is only through this that we generate a conscious awareness of the breathlessness and the unpleasantness that is associated with it. So, it is because of the limbic system input that patient feels bad, right, and becomes more and more aware of the breathing. Otherwise, you and I are not aware of our breathing, right? But patient is the whole time thinking about his breathing because he's aware of it only because of the negative inputs coming in through the limbic system. So what opioids does is it blunts the perception of breathing discomfort. It does not improve the hypoxia. It just blunts the perception of breathing discomfort that the patient feels and thereby reduces the severity and the unpleasantness of it. Okay? So are you clear about that? Can I at least see some heads nodding? No? Okay. I feel so this online teaching is so unidirectional. I am really wondering whether you can actually understand anything I'm saying. But anyway, I suppose the circumstances, we can't do anything else. Okay. Right. So how should we start? Well, I wouldn't advise everybody to start because, again, as physicians or as doctors, our first thing we want to do is to start pharmacotherapy or add on another prescription. So that is not right. In palliation, it is not about adding to the list of drugs that we need to give. We really need to think through what is the best modality for your individual patient, and that is a call that needs to be made from one patient to another. There is no fit all practice in palliative care. Okay. So we start with a small dose of immediate release oral morphine. You can give it either BD or TDS. Then we titrate the dose, looking for improvement in the symptom, both the severity and the affective component. So when does breathlessness become bearable to the patient? Similar to pain. When does pain become bearable? So you have a threshold that you need to achieve. You cannot take away breathlessness altogether in this patient. Okay. So once you come to that decision, right now, patient is finding it breathlessness manageable. He's now becoming more physically active. He's beginning to enjoy his life. Then we stop the dose at that and we convert it into sustained release morphine. Okay. And if the patient is already on morphine, then you can do a 25% increment on this dose. Right. So I'm sure I would have generated enough anxiety in you all when I ask you to give morphine to a patient with respiratory disease, right? Should we be fearful? Well, the evidence says that there is no concern, no undue concern for respiratory distress if you use opioids in already compromised patients. And these fears are mostly unsubstantiated. And we have used morphine in these patients and we have not run into any problems thus far. That's because we do it very cautiously and under strict observation. Okay. But remember, giving a drug means giving a side effect. So constipation should be anticipated proactively. You don't want your breathless patient to become constipated. And you also need to think about the patient's conscious level or how whether we are affecting his conscious level. You don't want them to be unduly drowsy. Okay, so this is actually a patient that we managed. The team managed in Kalutara. So this gentleman is the man I told you about, the one who comes on poor days and becomes very anxious when he's given the acute bed and this particular medical officer is on call. He attributes this whole situation to bad prognosis. Okay. So you can see he has home oxygen. He's wheelchair bound. He refuses to move. So he had such a big anxiety that we actually, if we want to engage him in pulmonary rehabilitation, but the man was not willing. He said, how do you expect me to move? I'm too breathless. So then we had a counseling, which didn't work very much. Then we started him on actually a low dose morphine. And his perception of breathlessness reduced. He actually had renewed faith in us that we can actually make his life a little better. And then we engaged him in pulmonary rehabilitation. And this is what you can see, this man walking up and down during rehab. And we were actually able to take away the morphine because once the rehabilitation program succeeded, his breathlessness was manageable. So we didn't have to get him onto pharmacotherapy. So remember, it's a mix and match. The match you will have to decide as a clinician. That is why you need to hear your patient. You need to ask questions. You need to hear them out. You need to dig deeper than what we are doing at the moment. Okay. So my fear of talking about morphine is I don't want you all to be just prescribers adding on another drug. We need to collectively look how best to manage these patients. Okay, just a few more minutes. Right. Are we to give oxygen to the breathless patient? And that's another thing we want to do. We want to give oxygen to anybody who's finding it really difficult to breathe. Right? Well, oxygen can be given in different forms. For chronic refractory breathlessness, we give what is called as long-term oxygen therapy. That means patients who are hypoxic, especially COPD patients, if you give them 15 hours of oxygen, a day, you would have read in guidelines, it improves their prognosis. Okay. There is a mortality benefit in them, but they need to use it for 15 hours a day or more, right? Then ambulatory oxygen is what a patient uses when they are walking up and down or exercising. That means patients who are hypoxic or becomes hypoxic when they are exercising, they can use ambulatory oxygen. Now in palliative care, what we use is short burst oxygen. Short burst oxygen is also given to hypoxic patients. They are not given to a breathless patient. Remember, breathlessness has many more things than hypoxia. Okay, short burst oxygen is given to the hypoxic patient who is being treated for palliation, where you ask them to do their activities, and for early recovery from that physical activity, they can take some oxygen. So, for example, patient goes to the toilet, comes back, he's struggling to breathe, he can take a short burst of oxygen to improve his breathing, right? Oxygen, domiciliary oxygen or home-based oxygen is a talk on its own, so I will not spend more time here. But remember, there is no place for oxygen unless there is hypoxia. That means the saturation has to be less than 90. Okay? Then if there is no significant hypoxia, then opioids is the management. If you want to give pharmacotherapy, opioids is the management to reducing breathlessness and not oxygen. And oxygen is a drug and it has its side effects. What are the side effects that oxygen gives? If you give oxygen to a patient, it reduces his life space. That means the man can't mobilize beyond his oxygen cylinder, right? He becomes physically bound to his oxygen cylinder. He becomes so dependent, both psychologically and physically. And that dependency will further worsen his quality of life, right? So do not unnecessarily think that you need to give oxygen. Oxygen can be detrimental to patients with type 2 failure, especially if they don't know how much to take. Oxygen is a costly drug and it has a small fire hazard. Okay? Right. So now you do, let's assume the thinking cycle is dominant. You do a lot of non-pharmacological measures, it doesn't work. Then you can give a trial of therapeutic low-dose benzodiazepines if anxiety is driving the breathlessness. You have to, that is why in your history you have to see whether anxiety is driving the breathlessness or not. Okay? Right. So the dying patient, last slide, I think. No, one before the last, sorry. No, two before the last. So the dying patient, if he's on oral morphine, you can convert it into subcutaneous morphine. You can give him a small dose of midazolam, again subcutaneously. And if it's hypoxic, you can give him oxygen. But remember, dying patients need to communicate with family members. They need to feel that they are surrounded by their loved ones. You tie them up to an oxygen cylinder with a mask on his face. Nobody comes near, nobody talks. And the poor man dies in isolation. Okay, so remember, whatever the intervention you do, does it carry a treatment outcome that is within your goals of care? Right. So, just to summarize, we need to assess, optimize, and reverse our management strategies when we are managing breathlessness. So, a few things that we can do for the functioning cycle, you have rehabilitation. For the thinking cycle, if there's anxiety, you need many other methods of doing managing anxiety, breathing techniques, handheld fans, cognitive approach, and oxygen if hypoxic, and opioids and benzodiazepines. So many modalities of managing breathlessness outside of managing heart failure or COPD, right? Okay, so this is the last thing. This is the stepwise management to dyspnea. This is just a summary of what I told you. And this is summary of what I told you. But remember, there is no going up the step. I think everything must collectively come together in palliation, and that should be the idea. Okay. So last slide, severity of breathlessness is unrelated to measurable parameters. So it's unrelated to hypoxia or hypoxemia. The most effective regime is concurrent use of both pharmacological and non-pharmacological measures, and opioids can be safely used to reduce the subjective sensation of intractable breathlessness.